Thank you, Dr. Amish. And moving forward from non-small cell lung cancer to small cell lung cancer, we all know that in extensive stage small cell lung cancer, immunotherapy has given us OS and PFS benefit. However, the data I'll be discussing is on limited stage small cell lung cancer, and we know that about 15% of small cell lung cancer are limited stage. 50% of them are progressing to brain mets which have poor outcomes, and median age of diagnosis is about 60 years. And mostly, nearly 90 to 97% of these patients are smokers. Initially, when they present, there is a good performance status, ECOG 0 to 1, but about one third are referred to us in the later stage. Outcomes have been of about once 90 days, the median overall survival in limited stage. The unmet need has been that patients respond beautifully. Nevertheless, the overall cure rate remains low. And despite having initial sensitivity to chemoradiation, majority of the patient relapses, and just about 30% of limited stage lung cancer are alive at 5 years. So the 5-year overall survival is very dismal in this category of patients. 50% of the patients recur in thorax, about 20% in brain. As we all know, it is limited stage is defined as the lung cancer which is can be encompassed in one thoracic portal, and which includes the renal lymph nodes, pleural effusion if it is negative cytology, and it usually corresponds to stage 1 to 3B. As I told you, one third of these patients are in limited stage. Limited stage, sometimes they undergo surgery and then they present to us with further treatment in which chemoradiation is given, but majority of them are concurrent chemoradiation, and PCI is a topic which is debatable. As of now, good performance status patients are given concurrent chemoradiation. Poor performance, sequential therapy can be tried. Surgery is in few patients, and there is no immunotherapy before this trial for limited stage small cell lung cancer. Cisplatin with etoposide is given in majority of the patients, although carboplatin can also be considered. And the standard radiotherapy regimen is 45 gray twice daily in 30 fractions. But in clinical practice, it is once a daily because it is more tolerable, logistically more beneficial, and compliance is better. The dose and fractionation differ in various countries and treatment can be heterogeneous. Nevertheless, the concurrent chemotherapy is preferred compared to sequential. And sequential is only considered for patient with poor PS, comorbidities, or high volume disease. Prophylactic cranial irradiation, more than 50% are prone for recurrence in brain, and it is recommended on patients good PS and age less than 60, and in European setting it is less than 70, and it also depends on the toxicity, patient's preference, and various other clinical factors. In few studies, the overall survival has increased by about 5.4%, and brain metastatic risk has reduced by 50%. However, MRI surveillance versus PCI is a better study, and we need a randomized control trial to find out what is best for the patients. Immunotherapy in extensive stage small cell lung cancer, we have the data of carbo-cis with etopo with durva, or carbo-etopo with atezo. Both are category 1 recommendation and are well tolerated, and patients after completion of therapy continue as a maintenance therapy with immunotherapeutic agent. But in Limited stage SCLC, only Durva is approved, and the trial design was Adriatic. It was a phase 3 randomized double-blinded study, multicentric international trial, in which patient who had not progressed following concurrent chemoradiation were randomized 1:1 with Durva maintenance versus placebo, and 4 cycles of chemotherapy were given, 3 were permitted, and radiation, as I told you, was either BID dose or OD dose, and RT should commence no later than end of the second cycle of the chemotherapy. The dual primary endpoints were overall survival and the PFS, and the secondary endpoint was again OS and PFS in the arm in which tremelimumab was also given. Nevertheless, we are not discussing that today. The, the biographic baseline characteristics were well balanced between the two studies, and they were keeping in mind what we see in our day-to-day clinical practice as well. The first primary endpoint was overall survival, and the graphs are speaking for themselves. It was more than 20 months benefit of giving Durva in limited stage small cell lung cancer, and the overall survival was 55 months versus 33 months with hazard ratio of 0.73. Across all the subgroups, it was beneficial. The PFS, that was the second that was the second primary endpoint, and it had also had significant improvement. It had almost doubled from 9.2 to 17, and Durva is the only immunotherapy to show a median PFS benefit in this category of patients. Again, all subgroup of patients responded very well to this Durva maintenance. Benefit of PCI, as I told you, is still not clear. There are various studies in pros and cons in both sides. Nevertheless, in subgroup analysis, if PCI was given or not given, the addition of Durva benefited in both the category of patients, and the PFS also benefited with the addition of durvalumab. The most frequent side effects, we all have been using this drug. It's usually well tolerated. Hypothyroid is one of the side effects, and radiation pneumonitis. There are chances that it might increase with the immunotherapy, but in the practice, we have seen that it is, if a high index of suspicion is there, it can be managed, and it's not common that these side effects are seen of grade 3 or 4 category. So Durva is the first and only approved immunotherapy in limited stage small cell lung cancer, which has shown both OS and PFS. Patients with limited stage are treated with curative intent, and despite high rates of initial responses, long-term outcomes are poor. Hence, maintenance with durvalumab is beneficial for these patients. So consolidation has given us statistically significant and clinically improved OS and PFS. The overall survival with hazard ratio of 0.73, 6 months versus 33 months, PFS of 16 versus 19, which are both are significant, and hence Durva consolidation up to 2 years is a well-tolerated regimen and has benefited these patients across small stage lung cancer limited stage. Thank you so much for your patient hearing. Thank you, ma'am.
Thank you, Dr. Mittal. I'll invite some questions from the floor. Is there any question? I think everybody is satisfied. Thank you.
PFS is 16 months and OS is 55 months, more than 3 times in a small cell lung cancer. Is it possible once the disease progresses, then patient surviving till 55 months?
I think the crossover was also allowed. Probably that is the reason that the OS is beneficial in these patients.
A crossover, but crossover means already they were in the durvalumab arm.
No, on the placebo arm,
yeah,
when they progress.
I'm talking of the Durva arm only. From 16 months PFS, the OS is 55 months. More than 3 times in a small cell lung cancer once it progresses.
So yes, that is a point of discussion. We don't know the exact answer for that. Probably when we use it and we'll get to know in our own patients, then we'll be in better position to
Sure.
answer that.
Okay.